list the chief complaint, okay? So you give a succinct HPI to us. Amber's on the way down.
Okay.
And then you get into relative family history, medical history, medication history, that sort of thing. And then you get into a relative or pertinent review of systems. And then you get into the physical exam. And when you present the physical exam, it's done in a certain order. First you give me the vitals. Vital signs were stable, or in Paul's case, I think it was Paul's case today, the blood pressure was 145/95, and so on. And then you give a general, the patient appears stated age. Then you do the HEET, heart and lungs. You work your way down. It's done in a certain order. So when Shannon was presenting today, she came out and said that the heart, she started with the chest. No, you don't start with the chest. You start with the vitals, then a general assessment, then HEET, and it's all laid out on this 2-minute thing here. You get 2 minutes to tell us about this patient, okay? And if you just, I shrink it down and plasticize it or laminate it, whatever you call this, and that way you can have something to work off of. But it needs to be in this order. It doesn't need to be all over the place. I know you haven't had this yet, so that's just what I wanted to present to you. Then when you get done with that, what is your assessment? My assessment is I think he has a pleural effusion. The plan. My plan is, what's your plan? I don't care, we don't care if the assessment's completely wrong, if the plan's completely wrong. Give it a shot. Okay? So Ms. Hicks is running this full page off upstairs. So take it and look at it. But when you come out of a room, the discussion should start exactly as it says here. Okay? You want to add anything yet? No. If you lose it, I have copies.
Bring that with us to Good Shepherd.
You can bring it with you, that's fine.
The more and more you do it, the better and easier it'll come to you.
Yeah.
And then we'll kind of give you tips and positives and, you know, feedback immediately so that you can learn from that each way.
We'll redo it. We'll bring it out. Thanks.
Absolutely.
She's nice.
So, we obviously didn't realize that hadn't been presented to you. We apologize for that. Again, that'll be something that you'll continue to develop, and by the time you get out on rotations, you're going to have that down, and you're going to be that much further than any other PA student that's going out on rotation that's not from this program. We've gotten tons of great feedback, and they love our students because you guys are very well prepared, way more prepared than I even imagined being whenever I very first graduated. So made some ground shaking changes. It's good. All right, so cardiology, laboratory, and medicine is what we're going to focus on today. And then at the end of this, and I'm sorry I didn't get this to you earlier, but I was kind of updating and highlighting the things that we really need to focus on. There's going to be some details and getting into the weeds of specifics with this, but then you've already had some deep details for like lipid panels due to hypertension that Dr. Britton already went over. He go over the details of the cholesterol panels and the lipid panel. And did, I know he mentioned it, did Dr. McNeil go over the details of it? Oh, well then I will. So obviously you don't have the normals and stuff like that. You're going to get that in here, but again, normals vary from place to place. So on your test, not only in this facility, but on your pants and your PANRE, you will always be given the normals. So you'll be able to analyze those results and then make your decision according to the treatment plan. This and so forth to help you answer the test questions, okay? Then after this, I have on your schedule adult testing, but sitting in on the radiology lecture as well as a couple of the others, we've pretty much covered all of that already. So what I'm going to do is actually answer any questions that you might have according to the upcoming test, and maybe give you some key pointers or pearls to absolutely have in your toolbox to utilize for practice, okay? Agreed? All right. So, moving right along. I didn't do objectives, I just now realized that. Our objective is to learn lab medicine, know what to order. Off of those orders, obviously, you're going to be assessing the patient's presentation and then making your decision on how you're, or what you need to order, and then you're going to be getting those results, analyzing it, and treating accordingly. Every lab, regardless, is going to have the same objectives. So I guess I could cut and paste the lab medicine from a previous lecture. All right, so one of the most important things with cardiology is your emergent acute MI, and that's what we've all been kind of studying the EKG for. And again, not necessarily ruling in and confirming a diagnosis, but definitely you could rule it out by that, as well as having a high suspicion. Clinically, in the emergency room, reading an EKG, you're going to be more sensitive because that patient's usually going to be presenting with symptoms appropriate to an acute attack, whereas in the clinic, a patient may just be coming in for risk stratification, an annual physical, or lo and behold, they came in for a chief complaint of something else, and as you were putting your hand on the doorknob and leaving, they said, oh, by the way, I've been having shortness of breath, and my chest has been hurting when that occurs when I do my morning walks. And you're like, okay, forget everything else we've already just done, let's address this. Okay, so acute MI, which is defined by the imbalance between your myocardial oxygen supply and the demand that your myocardial muscle is requesting. So obviously, that heart muscle requires a certain amount of oxygen supply from the coronary arteries themselves. So even though your heart supplies your whole body with the circulation, those coronary arteries supply your heart muscle, and those are the ones that you're seeing on those EKG tracings. So when you're looking at the families and cousins, brothers and sisters, you're looking at specific coronary arteries, of which you guys have already put that all together, because you have that nice graph of the RCA, LAD. You guys all have a copy of that in one of your lectures? Can somebody say no if you don't? The one that actually shows you where the lesion is, according to the siblings and the cousins?
Scott has it.
Okay, Scott has that, and then does it identify the actual coronary artery as well?
Yeah.
He gave us a chart that looked like this. It says like MI, leads, arteries, and which side of the heart.
Okay, good.
And it tells you like RCA, LAD, LAD, insert.
Right, and then have you guys seen that chart also that's got the color that goes off of the 12 EKGs? So that you know that it's, 2, 3, and ADF is inferior.
Yes.
Okay, so those are the things that you have to absolutely keep in your head and know those two charts. You're going to have questions on your boards. You're going to have questions on these tests according to those two charts. So know this. All right. So again, injury is going to be represented on that EKG reading. And then myocardial necrosis, which is deterioration of the muscle itself, spilling out the contents of those cells, is where you get the biomarkers, which is what we utilize in lab medicine to evaluate that. So that necrosis is associated with a thrombotic occlusion, which is a blockage, which is what an infarction is. So you've got a blockage, decreases the blood flow, the oxygen supply to that muscle and that cell tissue. Those cells start dying off because of lack of oxygen, and the muscle itself dies and scars and makes changes thereafter on your EKG, which is the Q wave. If it is a large enough MI, of course, depending on where it is in the heart, could affect the septum, which we all know is very important for the electricity conduction through the bundle of His and the Purkinje fibers, being the left and right bundle branches, causing a block from that scar tissue. All right. So with the thrombotic occlusion, you can also have an aggravation of that due to atherosclerosis, which is the buildup of plaque, which is why an elevation of your cholesterol levels, being your lipid panel, increases your risk of atherosclerosis, because those are the components that build up those plaques. Yes, thank you, awesome. So as those plaques build up, that decreases the diameter of the lumen of the vessels, decreasing, again, the blood flow and oxygen supply to the tissue. I didn't count them, so if you have extra, I pass them on back. But if you don't have enough, raise your hand and have them pass them to you.
Oh, you okay?
Yeah, I twisted my knee this morning already when I was getting my daughter out of the truck, so it's bothering me. I do need one of those. Just whenever you get to the end. So, again, the atherosclerosis building up, causing the decreased narrowing of that lumen. And then the constriction, whether it be from a drug that somebody did, an illicit drug that can cause vasoconstriction.
Cocaine.
Yes, exactly. Which is the #1 cause of a presenting young adult in the ER with chest pain. It's also why we usually say, well, if they're very, very young, you better get a very strong drug history, because the #1 cause of acute MI in your young adults is due to cocaine use. All right, so moving forward with that, with the plaques building up and the vasoconstriction, again, decreases the blood supply, causing more probability of an ischemic event and possible infarction. Ischemia is the decrease of oxygen supply. Infarction is the actual starting to have necrosis and damage. Okay. The next two are very, very important. Next two lines for clinical EKG findings. We're not in Dr. Vanetta's world today. Right now. So, by definition, ST elevation, ST is the segment between the last part of the QRS complex and the first part of your T wave. That's the ST segment. When we're talking about elevation, we're meaning elevation above that patient's baseline. Everybody understands how to get that baseline now? Okay. No ST elevation, again, is an in-STEMI or non-STEMI. I don't ever like to just say in, because M and N can be misconstrued. And so just prolonging it or making that longer, there's no more confusion with that. So total occlusion of the blood flow is going to cause that ST elevation. Partial occlusion is going to cause a non-ST elevated myocardial infarction on your EKG. With that partial occlusion, you may show ischemia. Ischemia in clinical EKG reading is ST depression. So you've got ST elevation, ST depression. If that ST segment falls below baseline, you've got decreased oxygen supplied to that coronary artery, which is ischemia by definition in the clinical world. Regardless of which way the T is pointing. Okay? So either of those, you need to know that there is an abnormality on that EKG, and we need to make sure we're getting a very thorough history of that patient and their family and all of their risk stratification, essentially. You better start running those risk stratifications, asking questions so that you can get that calculated. All right. We've already talked about no blood flow leads to muscle tissue death, spilling the biomarkers into the circulatory system, which is what we calculate or what we measure. So we've got a patient in the ER that is having crushing chest pain. Usually the pain in and of itself is so significant, that's why they get diaphoretic, they start sweating. Sweating is also one of your first precursors of vomiting, and these patients a lot of times will have nausea. So those two adding and kind of doubling on each other, then you also get that clinical picture of that patient having crushing chest pain, scared to death, so their heart rate's probably up because they're so anxious, which increases again your cardiac demand for oxygen supply and is worsening their symptoms. They get nauseated, they're diaphoretic, they get caloris as well, and they literally are panicking. So that is a dead onset clinical presentation of what an acute MI. If you see that clinical picture and then you see an EKG that has ST elevation, before you even get the enzymes or the biomarkers, you know that there's an MI going on. Okay. Obviously, you're going to be getting the rest of the vitals, so you're going to correlate that again with their pulse oximetry, and that'll tell you whether or not to utilize the oxygen. You're going to be looking at their blood pressure as well, and that's going to help you determine stability. Obviously, an unconscious patient is always going to be unstable. So you're going to expect their blood pressure and their other vitals to be out of whack as well. So statistics. The 2000, I tried to look at the most recent stuff that I could find. ESC is the European Society of Cardiology, and the ACC is the American College of Cardiologists. So they had a conference updated in 2007, most recently in 2012, that had the global task force and yada, yada, yada on the universal definition of an MI. They incorporated the evidence of myocardial injury based on those biomarkers of cardiac damage, and preferably the TN is troponin. C, I'm assuming, is cardiac. So CTNI or CTNT. So we've already had Scott talk about troponin I and T, and he said it doesn't matter. It's going to vary from facility to facility, whichever one that they utilize. Most commonly, it's probably going to be because of whatever machinery that they have in their lab. So again, I will give you the normal values on a test, or I will just frankly say your troponin is elevated, or it's not. Okay. So they're saying they've definitely shown evidence enough to really put this into their definition of a myocardial infarction, superimposed with the appropriate clinical situation and ischemic symptoms. So that picture that I just presented to you, think of that. So the initial EKG, look at this, is diagnostic. of an acute MI in about 30% of AMI patients. So that means 70% it doesn't show. That doesn't mean that it's never not diagnostic, obviously, right there in black and white, okay? So, clinically, we do call it, when we're talking to the cardiologists or anybody else, we're saying, I've got an EKG, patient's very symptomatic, showing an inferior wall MI with ST elevation of 3 to 5 millimeters or whatever it is that you're seeing, with reciprocal changes in the interior lateral wall. Obviously, that's a no-brainer. And so you're going to have ST elevation. You don't have to say that. You're going to have ST elevation in your inferior leads being Stacy.
2, 3, 8.
Oh, sorry, she's the only one that wasn't looking at me. Sorry. So she didn't hear me. Everybody else said it. 2, 3, and AVN. And then what should I see as far as reciprocal changes? If there's ST elevation in your inferior, and I said there's reciprocal changes in the interior lateral. I don't have to name the leads right now, but
ST depression?
yes. So that's what you're looking at. Okay. All right. So your troponin testing is the most useful when patients are having a non-diagnostic EKG changes. So again, I have a clear-cut ST elevation with reciprocal changes. I know it's an MI without even having my troponin. Does that mean I'm not going to order it? No. I'm continuing and going ahead and ordering it because then you're going to have your baseline. And we're going to learn, again, we've already been mentioned, when is it that our troponin is going to start rising after the onset of symptoms or the onset of actual damage with cell tissue death. Okay?
3 to 5 hours.
Good. 3 to 6 hours, which could be 4, because that's in that range, right? I'm going to give you a graph, which is in your just a handout there. So this one doesn't say hours on this graph here. It just shows you essentially why we use troponin, because it does rise quite significantly in the beginning. But these down here are days, so it doesn't give you hours. So then I found another graph up front, up top here with cardiac enzymes. This is obviously an older one because they're calling them enzymes, not biomarkers. Whereas your troponin initially rises less than 4 hours. Now that's not with every case. If you get a troponin and it's initially negative, which you're actually going to get a number, but when your value is less or in that normal range, it's negative, okay? That doesn't mean that they're not having an MI. It just means that it's not showing up yet, and that's why we do serial testing. So it says an acute MI can be categorized into several groups based on their presentation. Within 0 to 4 hours after the onset of ischemic symptoms that include chest pain without a diagnostic evidence of an MI on an EKG is when you're going to really pay attention to these. This is essentially what you would call this patient in that lower case where they're having chest pain but they're not having EKG changes. We again call that an acute coronary syndrome because we don't have the definitive diagnosis yet.
I'm sorry.
Sure. So you've got a patient in your emergency room that's having chest pain that does not have EKG changes yet significant enough to diagnose an acute MI. You've done a troponin, and the reason we do a troponin is because you're going to be monitoring that. But again, they've got ischemic symptoms, which is the chest pain, shortness of breath, whatever else that they have at, and you do not have EKG changes yet. That's when your troponin is most useful.
And if it's positive, then you call it.
If it's already positive, yeah. If it's negative, you're still going to say that's an acute coronary syndrome.
Didn't he mention something about I don't remember if it was, I think it was for this, like you wait, you check it again in 3 hours or something to like,
Usually they wait 6 hours. It really depends on how significantly the symptoms are in your patient.
okay.
Okay. You also have to take into consideration, which we'll get into here in a few slides, what all is going on with this patient. Have they recently had a procedure? Okay, because you've got to take that into consideration. Has somebody been messing with their heart that would be spilling that over? Yes.
So at that point, we just admit them and watch their
Absolutely.
But you wouldn't send them to the cath lab yet because their EKG hasn't changed.
You're going to call the cardiologist and they're going to make that decision, but, and again, it's going to go off. That's why that risk stratification is so important. They're going to ask you, what's the risk stratification? And you're going to give them that number. It's just like your patient that comes in with trauma and they're unconscious or not unconscious, but they've got a decreased level of consciousness, and you do a mini mental status or a quick Glasgow coma scale. They want that number. Okay. So that thing you need to know as well. Have that risk stratification in your head, in your app. Keep using it. Make scenarios, put those numbers in, make it up, see what it says. Yes?
Are we gonna have to run that without an app, like on an exam?
You need to know the risk stratification. Duly noted. All right. So troponin I and troponin T. I'm from the era of practicing medicine before troponins even existed. So as I started emergency medicine, like my second year is when they started using troponin. They just had troponin I. I didn't even know about troponin T until recently. So see how technology continues to advance. This may change. You've got to keep up on it. But for now, right now, again, troponin T and I are specific for the heart. One is more sensitive and one is more specific. So the troponin I remains elevated longer than your CK and B, and it is more specific. Before troponins, again, we did CPKs and then CK-MB. MB was the component that was more specific for the heart. So we used that, and that was the strongest enzyme. Those are actually enzymes that would tell us about heart disease. But now we have troponin, and that's essentially wiped the CK or CPK and your CK-MBs off the board as far as why you would order that. Now, if you go into cardiology and you're monitoring them on the floor, those are the scenarios that you're going to use those enzymes. But not in emergency medicine, not in primary care. You all are being taught as if you're going into primary care, and a little bit as in emergency medicine. Okay. So the troponin I is more sensitive but less specific. Those are the normal ranges again there. I am very familiar. I just always said if it's greater than 0.03, it's positive, and we got our diagnosis. But again, that was when I was the only one that existed. Did you have another question?
So is troponin I, I'm sorry, more specific or less?
This is more.
Does one of them says BT?
So I think that, yeah, I think that that second part of that sentence, and I may have like fallen asleep or something last year when I was creating this, I think that that one's supposed to say that it's more sensitive than the troponin T, but less specific.
Okay.
And I think that's the comparison of that second one. I will look that up and confirm that for you guys.
So is that like the ultra-sensitive test that you're
Yes,
talking about?
T is ultra sensitive. And the only way I know that for sure is because I kept hearing Scott saying that over.
Wait,
I'm sorry. Okay.
which one?
Sorry, I just wanted to.
So we're not talking about CK
So-
and B.
Why is CT and I is more sensitive? Didn't you just say more sensitive than T, or less specific?
Is that CT and I supposed to be CT and T?
But didn't I just say T is more sensitive?
Because sensitive would be a lower number, is that what you're thinking?
I'm the same with you. Okay.
So, look at this graph. Does it help? Both of them rise really, really quickly. Troponin T starts to drop off faster. I'm not going to ask you about which one's more specific and which one's more sensitive on T and I, because again, it doesn't matter. It depends on where you work. So don't stress out about that. Sorry.
Did you say T drops off faster?
T, I'm sorry, I looked at that wrong. T stays in there longer. I drops off faster. Is that what you were getting ready to say?
No, I was just wondering about the cardiac enzymes, just in case you're tested on this, which would be the limit. We've been given different numbers a couple times.
Again, oh, as far as the rise and peak of normal days?
So,
What?
because I know the pearls and then Scott's match, but then this one's different.
Okay, well, let's go off of the Pearls and Scots then.
I just want to make sure this so we don't get.
I will, make sure if it's on the test, because those test questions are from banks that have been asked for many years, and I just go in and print them, so I will make sure that those numbers are off of Scott's lecture material.
Okay.
Myself a note here. The big picture of why we show you these is because, one, we want you to know which test you're going to be using. In the scenario, the reason why my T and I is really so special. I can't see up there and I can't see down here having glasses on. Having a problem here. These aren't bifocals. So if you've got a patient that their EKG is a non-STEMI, and you're wanting to try and rule their acute coronary syndrome as being an MI or not, to send them on to the cath lab, then you're going to be repeating those. And it's usually 6 to 12 hours later, and they continually repeat them, usually 3 times, so that they can watch that. And then after a few days, they want to start seeing that coming back down, because you can have more than one MI in a series of days, especially if they didn't go to the cath lab. So again, if you're practicing in BFE, which is where I'm from, you're always going to call the cardiologist. They're going to say, fax me the EKG, or however they get it now, since everything's digital. Again, I'm old. We didn't have digital EMR, so we couldn't just send it in the computer. We faxed it, and then he told me what to do, and that was before I got my enzymes back. That was also to help me determine whether we were going to treat them with medications such as clot busters before we ship them. There's certain medications that you can't give them if they're going to go ahead and capture them within 12 to 24 hours. So again, why we're teaching you all this, I don't want you to know all of those specifics yet, but that's why we do some of these lab tests that you're not going to act on immediately, but you have to know those numbers for the immediate future within the next 24 hours, okay? So practicing medicine sometimes, especially in cardiology, is not just the immediate, it's also to prepare for the next 24 hours on the intervention of what they're going to do to help them. Okay. So I'm also going to write me a note on this last slide.
So to just confirm that each hospital varies. I just looked back at my notes from Scott, but I didn't see any specific numbers from Scott. So the peak time is more important.
Yes.
Okay.
And he actually mentioned these numbers because I'm familiar with the .03 and the .1.
Yeah.
Those are the most common, but again, I wouldn't bet $1 million that every facility has those numbers. Okay? All right. So therefore, your troponin test, blood test, is preferred diagnostically for acute coronary syndrome. That's what we've been talking about for the last 15 minutes. Troponin is irreversible as far as necrosis. So that is when that is going to elevate, is when you actually have cell tissue damage, not just hypoxia, but damage itself, the cell death. So anoxia, which is also hypoxia, contusion, and inflammation. So obviously, if you've got a patient that is having chest pain, and it could be cardiac in origin, but it also could be due to a contusion of the chest wall from a car accident, then we don't know for sure with those EKG changes and the elevated troponin until that calms down. If the patient had an infection as well that was cardiac in origin, so endocarditis or myocarditis, that's going to elevate. So those cells are being damaged at a slower rate, so your troponin's going to be elevated. It's just not going to be as high. All this slide is trying to tell you is that you've got to take everything within the context of the scenario that's going on with this patient. Okay. I don't know why I put that CKMB in there again, other than the fact that that's what it stated in your book, and if you guys were reading the book that I had given you, then this way I can clarify that for you again. In the ER, I have never ordered a CKMB since they came out with the troponin. We had that. Okay. So EKG is most important. Troponin is going to be your next. And then, again, you've got to take that into context of what all else is going on with the patient. Making sure they haven't had any previous recent procedures. And with this says 7 days. I know you were given 10 to 14 days. I would definitely just say go with the longest if you're trying to determine whether or not they're having a new event. So if their troponin's elevated and they came to your ER and they were discharged 8 days ago from their stent placement down in the city, and now they're just having some mild chest pain that you're trying to determine, are they having an MI again? Are they re-occluding? Are they occluding somewhere else? Or is this just residual that's going on? So then again, you're going to get that value and compare it to their previous, so you're going to get their past records from their discharge. And then you're going to, again, start serial testing them so that you can see, is that continuing to climb or is it on the decline? See how that story will play out. Okay. And I would do that even if they were 2 weeks out from their procedure. So I highlighted in red the most important things for you to remember. Troponin concentration rises 3 to 6 hours after the onset of ischemic symptoms. And again, if the patient awakened by chest pain, I don't know exactly how long that's been going on. But it can be delayed for 8 to 12 hours. Again, that's why they do serial. So I usually order it in the ER. If I don't have a specific diagnostic EKG that confirms and they need to be transferred, we admit them to the floor. We repeat their biomarkers, their troponin, again, usually 8 hours was our protocol. And then again, the following morning, 12 hours after the second one was done. All right. So, the other biggest thing, CKMB is not useful with acute coronary syndrome. I changed that slide, took out the enzymes, because obviously I did that yesterday, so I changed that again. It's serum 5 biomarkers. They will help the prognosis with a STEMI. We used to think if their troponin was hugely elevated, that they had a massive MI and that I should see EKG changes in more than one area. But that, they've done studies and they've really not correlated that. And I've talked to several different cardiologists over the past year. My whole family's decided to pay all of their bills. Had 5 family members in the matter of 15 months. 4 of them have been at Oklahoma Heart, and then my grandfather's currently at, he was at Mercy, and they just transferred him to OU in Edmond. And he's having the other leg stinted right now. So he did great the other day. All right, so again, this is just repeating. Go ahead. Did somebody ask me something? No, I just sneezed. So, oh, it was a sneeze. So here's where you would use the CKMB or the CPK, and that is just mainly, I was not even talking to you about that on the slide, sorry. The cardiologists use it to determine the amount of inflammation after a procedure that they've done. So your stent placements, your CABG, which are the acronyms that were given to you the other day. So PCI is percutaneous coronary intervention, and PCI being intervention can either be by stenting being angioplasty, which is PCTA, or CABG, which is coronary artery bypass grafting. And that's the one that they crack the chest, open them up, and literally go in there and replace those coronary arteries. They usually will take them, harvest them from their lower extremities. This is just giving you more details of a CKMB. But again, the CKMB is going to be elevated even with just somebody that's been in SBT for a long time. So it's really not a good value to look at for acute MI. Something as simple as alcohol use and hypothyroidism can be causing that, or a long-term collagen disease because of the pulmonary problems giving you hypoxia. So it's just not a good biomarker to use. So CK is the short for CPK, so creatine phosphokinase, and muscles will spill that anytime there's activity at all. So somebody that's ran a marathon, their CPK is going to be elevated. Now the CKMB being the heart, again, you're increasing your heart rate when you're running, and it just depends on the rate of how fast and how slow they've raised and lowered their heart rate there. Rhabdomyolysis, I know somebody mentioned that to you guys the other day. Has that been introduced to you as far as what that term means? Okay. Rhabdomyolysis, myo is the term for muscle. Lysis means you're destroying those muscle cells. Rhabdo, not sure what that one is. I should striated, thank you. So striated is in skeletal. And cardiac, right? Okay. Specialized striated muscle in your cardiac. All right, so obviously any activity with those, so that's why the CPK or the CKMB would be elevated with that sustained fast heartbeat. There's where it shows your drugs and thermal burns and everything else. Infections can cause that to elevate as well, and I gave you, just refer to this, the very last page, I think it is. Nope, second to last page. Just a picture of the biomarkers being elevated according to different conditions of the heart. So acute myocardial infarction, see the level of that raised is pretty significant. Myocardial injury, and that could be ischemia, or it could just be a contusion, a small contusion, any small area that's being affected. And that's where I guess Dr. Bowman has injury patterns and stuff like that, but again. And then myocarditis, which is your infection. So just think of all of the cells being affected by that infection and it being disseminated, being spread throughout. So rhabdomyolysis, I didn't finish that, I'm sorry. So rhabdomyolysis is the lysis of the muscle cells. You're going to see that with any condition that's causing deterioration of the muscles, so wasting of muscles. Just inactivity for a long period of time causes your muscles to reabsorb, right? So atrophy of that muscle, such as your nursing home patients. Rhabdomyolysis is something that you really need to be considering and thinking of if you've got an elderly patient that has fallen and they can't get up. And they have laid there for 3 days. So they have not hydrated, they're dehydrated. Their body's trying to use whatever's in your body to survive on, so it starts breaking down your own tissues. That is where you're going to see rhabdomyolysis a lot. And that causes, obviously, your CPK and your CKMB to elevate quite a bit. The other things, as far as the infections, just literally anything. A virus infection, a bacterial, fungal, parasitic, so any infection whatsoever is going to cause that. So, again, non-sensitive. CK, I've already kind of went through this ad nauseum. Again, you're not going to use this unless you're going into cardiology and you're trying to determine how much damage and how the progression of their improvement and healing is by watching these levels come back down. Here's all the conditions that cause necrosis and inflammation of striated muscle. Quite a bit of different things. So again, this is why it's not sensitive to a heart attack. And then we're going to move on to congestive heart failure. So with congestive heart failure being another cardiac condition, the labs that you're going to be looking at will be essentially BNP is one of the ones that they really link to congestive heart failure. This, again, has recently come out, and that BNP stands for brain natriuretic peptide. BNP sounds very close to BMP. So when I order that, I would say, if I'm giving a verbal order, I need a BNP to rule out congestive heart failure. Or I would say, I want a brain natriuretic peptide, BNP, and just spell it out. Or I would say a basic metabolic profile, not BNP. And I hardly ever just use a BNP. A lot of the times you're going to need to look at their liver and kidney functions. So you're just going to do a CMP. Okay, so interpretation of BNP. BNP is kind of like the D-dimer that we talked about the other day. It's only useful if you're highly suspicious of it and you want a confirmation, or you want to rule something out. So as far as a DVT for the D-dimer or the PE, if you have a low suspicion, you didn't think it was going to be positive, you order it, the D-dimer's negative, you don't have to send them to the CT, or you don't have to go and do the Doppler ultrasound, compression ultrasound. So you're saving that patient money and time. B and P, again, you're going to order this if you are looking at a chest x-ray and the patient's symptomatic as far as short of breath, and they've got rels and crackles, and they've got pedal edema, but they always have pedal edema. So that's not really definitively giving you the correct answer. And you're trying to determine, is this what I'm seeing on a chest x-ray, since it's bilaterally, is this pulmonary edema, fluid building up in their lungs due to congestive heart failure, or is this a possible pneumonia? Because they look very similar on a chest x-ray. And it took me years to be able to look at a chest x-ray and confidently go, that's congestive heart failure, not pneumonia, or that's bilateral basilar pneumonia, not congestive heart failure. So this is where your BNP comes in handy, as well as it is used for congestive heart failure to see that they're improving while you're treating them in the hospital. So again, you would get a serial or daily BNP, or every other day, however much diuresis and results that you're getting off of them. So you correlate these labs with their condition and what the answer is trying to tell you. That's when you know whether or not to order it. So as far as interpretation of the BNP, if I have a patient that has a history of congestive heart failure and they come in with chest pain, their EKG is not showing us any changes as far as an acute MI, they sound like they're in congestive heart failure, I start to diurese them, I want the BNP to get me a baseline now to see what that value is. But all these other things can cause the BNP to be elevated. So if I were trying to utilize that and the patient did not have a clinical picture of congestive heart failure, you don't really use that to try and rule in congestive heart failure if you don't have the symptoms. Does that make sense? So for instance, my grandmother last year was admitted to Oklahoma Heart. She had passed out. She had an arrhythmia. It essentially was pre-excitation. She was having premature atrial contractions pretty consistently. She was having long runs of them, so therefore they shipped her down here because they didn't want it to go into a more lethal arrhythmia. With that, when she was admitted, they had her on the monitor. They were discussing over the weekend with the residents on whether or not they were going to cath her the following day, come Monday. And my question to the radiologist was, well, her troponin was just slightly elevated. Her EKG did not show that she had an MI anywhere. She does have ischemia, but that would be expected with a high tachycardia with runs for quite some time. I asked about, because he was going through the history, well, did she have a history of congestive heart failure? And I said, no, but she doesn't have pedal edema, and I wouldn't suspect that to be, did she have an elevated BNP? And he said, we don't even use that anymore. Okay. So I was like, why would you ask me if she, was having congestive heart failure when she clearly doesn't have ended edema bilaterally? And so I told him what I did, and with that discussion, he started literally doing the specialized tests that we're going to teach you. I've never seen another cardiologist ever do specialized tests, and I think it was because I said, I'm a PA and teach cardiology. And he started going, oh, I better do all this. It was quite funny. Anyways, but I said, well, why don't you use BNP? And he said, well, because of all these other things that can cause it. You know, I need to look at her kidney functions. I need to look at making sure she hasn't had a recent stroke or anything like that. So again, history, past medical history is going to be really, really important to determine what your lab values are telling you. So it's not just clear cut, oh, I've got this condition, I want this lab value, and this is what it's going to tell me, and it reads this number. It's kind of hard. So you've got to really know what you're looking for and what you are highly suspicious of your lab results actually telling you to determine whether or not to order. Okay. During the lecture last year, yeah, I put this one in here because of that. One of the students said, well, what's a pro-BNP? And I'm like, never heard of it. I'd never heard of it last year. So I looked it up. It's just more specific, and it really hasn't been implemented into clinical medicine yet because it's not really been proven to give you any additional benefit of information, even though we know it's more sensitive. So, if you have gods of time, which I know you don't, you can read up on that. So this gives you the definition of BNP. Even though it's a brain natriuretic peptide, I would have thought, well, it's being kicked out by the brain only. It is being kicked out by the brain. That's why if you've had a stroke or anything else, that's elevated as well. But a large amount of it is a hormone that's secreted out of the left ventricle, the muscle cells of the heart. And so when you have damage in that area, then that elevates it. As well as the fact that congestive heart failure is usually due to a low ejection fraction due to failure of the function of your heart. So that enlargement, you've got more cells that are developing, it's getting thicker but floppier, and that chamber lumen or filling capacity is smaller. So there's all the details of the difference between BNP and pro-BNP. But again, unless you go into cardiology, you're probably not going to need to know all of that, and you're not even going to use it in emergency medicine or primary care. You're going to let the cardiologist determine all of that. All right. So don't freak out about all of this information. I just have to give it to you. You don't need to know those numbers. So it looks like that the cardiologists are using the BNP as a prognostic determination as far as non-cardiac events versus cardiac events. But again, when the cardiology resident was telling me we don't even use that anymore, I'm thinking, well, this is probably old news, so I'm not going to make it learn. All right, D-dimer. So we're going to talk about this again because cardiovascular system is essentially what we're in. Your heart has a reason to exist, not only to supply your organs, but obviously you have to have the pipes, which are the vessels that carry the blood supply through. So the vascular disease being atherosclerosis is really, really important. And when you do have atherosclerosis in your arteries and veins, then we worry about that, not only for plaque development and causing occlusion, but decreasing the lumen so that a clot would not pass through as easily, or the breaking or unstabilization of that plaque breaking off, throwing a clot throughout that blood supply. So we worry about DVTs, not peripheral vein thrombosis. DVT is deep vein thrombosis. So we worry about clots in the extremities of above the knee, namely femoral, popliteal, iliac, and obviously aorta. In the arterial supply, because that's where the most force is for disrupting that clot and moving it, as well as that's where, when it pumps through, it's kicking it out to other places. The most important place that would cause a sudden event of death would be in the lungs. So a large clot coming from a deep vein going to the lungs was going to cause a PE, which is a pulmonary embolism. You should have learned this in pulmonology. So this is the highest reason why you would do the compression ultrasound, is if you've got a patient that is starting to have symptoms of shortness of breath or chest pain, which sounds like a heart attack, could be a PE, okay? So then you're going to start asking again, do you have pain in your lower extremities when you're walking that is relieved by elevating or rest? That's intermittent claudication. Intermittent meaning it comes and goes. Claudication meaning pain in your lower extremities and your legs. That is a telltale sign of a possible clotting of the lower extremities. Sedentary lifestyle, or just being sedentary recently due to an event, such as riding in an airplane for 12 hours or 6 hours or 8 hours. Scott already went through all of these the other day, but he went really, really fast. So a hypercoagulable state, no matter what that is. Pregnancy. Nobody's gonna volunteer. Sepsis being DIC, going into DIC, definitely. Recent surgery, most notably orthopedic surgery, because your bones are what are producing your blood supply.
Can trauma to like the chest sometimes cause a PE? Because my grandfather, he was a vet, and 2 weeks before he died, he was kicked by a horse, like right in the chest. And what they were thinking was it was a PE caused by some kind of bleeding that clotted and went.
So a contusion to your chest,
Yeah.
not just the chest wall. You can have a contusion to your heart, which we talked about just a little while ago. I don't know if you guys caught on. So what is a contusion? Bruising. What is a bruise caused by? Blood that is clotting in that tissue. So he probably had a pulmonary contusion, blood clotting in his lungs from that impact. And then it was pushed out.
I would wonder why.
Yeah.
They always just say, well, so we think there's going to be.
Right. So a large PE that is thrown from a deep vein going into a main stem bronchus is going to block off a whole lung and give you an immediate change with hypoxic events and cause secondary cardiac arrest. It's not that they just suffocate. They go into a fatal arrhythmia because their heart is responding to that sudden change in oxygen supply. Okay. So if you're suspicious of a blood clot in the deep veins, one, you're going to order the Doppler, or it's called several different things. I call it a lower extremity venous duplex scan to roll out DVT. That way they know what I'm ordering, what I'm looking for, and what exactly they need to be doing. They need to Doppler it so that they can get the actual flow, arterial and venous, and get numbers on that. They need to do the compression to, just like he was showing you in radiology yesterday, to determine and see if there's an actual clot that they can visualize and taking pictures of that. As well as, getting all of the calculations from that. So, I use old and new terminology just to make sure that they know that I want both and that I'm looking for a DVT. Because sometimes if you just order an ultrasound of the lower extremities, or the lower extremity being I need an ultrasound of the lower extremity, they don't know, is that venous or arterial, what are you looking for? What, are you looking just for damage because of trauma? Are you looking for a DVT? You've got to literally tell them so that there's no mistake. And they give you the appropriate report. So a D-dimer, which is why we've got this slide up, again, is a screening test. It's caused to be positive for up to 1,000 other reasons as well. The only time I would order it is when I thought it was going to be negative, so that I didn't have to order all of those others, and it would cover me liability-wise. Otherwise, if I think it's going to be positive, I'm just going to order the CT or a PE or the ultrasound to rule out a DVT. Okay? See how that plays in? Because you're going to get 50,000 different physicians and specialists telling you, well, this value means this or this or that. It doesn't matter. Just get the definitive test. That second statement is just saying that it can rule out a PE if it's negative. But if it's a low positive, you still don't know shit from China. So, does you no good. All right. The next labs that I'm going to talk about is important to cardiology again, because this is what's going to happen to this patient over the next 24 to 48 hours that I need to know this status. PTINR, PTT. Do they have any clotting disorders? Do they have a hypercoagulable state? They're also, you're going to do the CBC, which I didn't list in this. CBC is going to have your platelet count. I didn't give you guys a break, I'm sorry. Do you need a break? Let's break right here. And we're almost done, and then I'll just go over some more questions here. I'm horrible about that.
You still look fancy. I mean, you look fancy, but like it's for a
Just because you know
purpose
there's a
now.
reason.
Yeah.
So it's better to dress up with no reason?
It's more questionable.
Ah,
I would ask about it. Sure. Do you want to be interesting?
Whatever.
I don't want I guess I made an appointment last night. Just a light trim. Like a good trim. Yeah. Like I would have noticed. Like my sister had long hair like you. And like I felt like there was so much hair before, and I was like, and angina and stable angina are and now I can see
No, I thought of a positive. And one farm lecture, and then that's all. So we'll only have 11 lectures. I think anything was like these people turning in it, it's like, no.
You like your dog? I like how you. Your tone was lovely.
Over 6 months.
I think I hated you there. I cried. I was like,
I'm gonna try the tightest one.
I was in there like an hour and a half, and I was like, so bad.
Once I start crying, I can't stop. Because I just like crying about boring.
I noticed like slowly some finger snapping. That's really all I got. That's all I got. I don't want to work out today. I tried to do 30 minutes of cardio and then the resistance the old chest and back ain't what they used to be. I was like, oh. Muscle tone loss. I was like, oh yeah, I'll be able to do at least 6 weeks. I was like, that's hard. When I try to press.
Okay, awesome. I really appreciate it. Thank you so much.
I would, but I would kill all of you. It would be very bad.
Yeah, I'll get it done.
I think I might study like straight after class. So I can give myself a break before I go. Just study. Oh, binge studying. You have to binge. I know, I should have something exciting. Yeah. I need a rest.
So today when the assistant to get his hand checked out, he saw the VA, and he was asking like, oh, yeah, the mercury is really well. He's like, I wouldn't wish that on anyone.
Nobody like it's so hard to explain out loud. Nothing encompasses it. It's like fine, like but it's not going. But it's not. I don't think it's for time. But he said people are like hard if there's something.
I don't want to be too stick legs and like he's like I'm sure it'll be better and over my things like we didn't treat you better. I don't know. You don't have to but it's like I'm
scared of everything.
I will go to Stillwater. I'll go it's like right by Okarchi.
Did you finish your oath yet? So on your note, you said she's kind of like a recipe deal that you just don't have to do
It looks really nice.
I didn't do that. I didn't know question. But I still did.
I would die.
Research questions.
But I know probably
Honestly, that's are they really doing that? Okay. I was like, oh wow. That always happens.
Awesome. That's better than a cat video. Not doing a bad job.
That's cool. I don't know. I don't know what I want to know what it says. Like, at first, I thought you were saying I heard you say that. Every time I did it, like, maybe I remember seeing that. It's like, I wonder if that's even a good
It just makes it flutter the cat to the top. Thanks for not punching me, I appreciate it. That's funny.
But then he knows he knew Probably like, where's my notes? She always like, no, they were ones like, ABS, like,
Your responsibility is really out to it.
It wasn't about Yeah. And then she's like, oh, but this one has this one. Oh, you're in the hospital, let's go over like one thing after another.
They're trying this year, so they switched the curriculum for this year, and they added in some other classes, like trying, like,
Did you know anything about this?
they added like Spanish.
Like you like take history, but then they come in and like take
Med schools have been there since for a while.
And like a lot of mine, like sometimes like GI is covered in diabetes. That's my favorite kind of because I'm like everyone that yeah, and they don't expect you to know about it. Like and like and like kind of went through my like oh so this is this and like I was already familiar with but like it's like they're there to help you. It wasn't like oh so when I didn't know this why or you were there to like supposed to figure it out.
All the medications that we should ask them. And then they like go in the room and
like a lot of them so I didn't start
even though he's
so I just a little bit trying to help myself remember what, but it's not no.
Hey, Paul. Is Audrey okay? No, is she here?
yeah, she's ditching to go see her boyfriend who's graduating basically.
Oh, yeah, that is right. Okay. Oh, yeah, because you were taking her spot?
Yeah.
Okay.
So yeah, that's why I went.
You guys ready? Okay. So I just had a really good question. According to the proponent,